Hello. In this session, we will explain two very important concepts in health technology assessment. 1. The Incremental Cost-Effectiveness Ratio, ICER, and 2. Multi-criteria decision analysis. And we will also discuss how a regulatory authority can adopt these models in order to make an informed health technology assessment-based decisions. But before talking about the Incremental Cost-Effectiveness Ratio, we have to define two important metrics. First, the quality-adjusted life years, which is one of the most widely used measures in health technology assessment. A quality-adjusted life year combines two things into a single number: how long a patient lives and how good that life is in terms of health. It's essentially a way to measure not just more years, but better years. Here's how it works. We assign a utility value to a person's health state on a scale from 0 to 1, where 0 represents death and 1 represents perfect health. Then we multiply that utility by the number of years lived in that health state. For example, if a patient lives 1 year with a quality of life score of 0.8, that's 0.8 quality-adjusted life years. If a new treatment extends their life by 2 more years at the same health quality, they gain 1.6 quality-adjusted life years in total. Quality-adjusted life years allow decision makers to compare very different treatments, from cancer drugs to joint replacements, using the same yardstick, helping ensure that limited healthcare resources deliver the maximum health benefit. The second concept we need to be familiar with is the concept of the willingness to pay threshold, which is a key factor in health technology assessment and funding decisions. The willingness to pay threshold represents the maximum amount of money a healthcare system is willing to spend to gain one additional unit of health benefit, often measured in quality-adjusted life years. Think of it as a benchmark. If the incremental cost-effectiveness ratio of a new treatment is below this threshold, the treatment is considered a good use of resources. If it is above the threshold, the treatment may be viewed as too expensive for the benefit it provides. For example, if a country sets its willingness to pay threshold at $50,000 per quality-adjusted life year, a cancer drug that costs $40,000 per quality-adjusted life year might be approved for reimbursement, while one that costs $100,000 per quality-adjusted life year might not. Willingness to pay thresholds help policymakers make transparent, evidence-based decisions and balance patient access with sustainability of healthcare budgets. Now we come to the main topic, which is the Incremental Cost-Effectiveness Ratio, or ICER, and it is one of the most important concepts in health technology assessment. ICER helps decision makers compare two interventions by asking, how much extra do we need to spend to gain one extra unit of health benefit? Here's how it works. We take the difference in cost between a new intervention and the current standard of care and divide it by the difference in outcomes, usually measured in quality-adjusted life years. For example, if a new cancer drug costs $20,000 more than the existing treatment, but gives patients half a quality-adjusted life years, more of healthy life, the ICER would be $40,000 per quality-adjusted life years gained. Health systems then decide if that price is worth paying based on their willingness to pay threshold. If the ICER is below that threshold, the intervention is considered cost-effective. ICER is powerful because it combines clinical impact and cost into one clear metric, making tough funding decisions more transparent and evidence-based. Now we will shift gears to talk about the multi-criteria decision analysis, or MCDA, and see how it helps decision makers in health technology assessment. MCDA is designed for situations where looking only at cost effectiveness isn't enough. It allows us to evaluate multiple factors side by side, not just clinical effectiveness and cost, but also safety, innovation, equity, patient preference, and the size of the unmet medical need. Each factor or criterion is given a weight to reflect how important it is in that specific decision. Here's how it works step by step. First, we identify the criteria that matter most for the decision. Second, we assign weights to each criterion. For example, clinical effectiveness might be worth 40%, cost effectiveness 30%, equity 20%, and innovation 10%. Third, we score the technology against each criterion, usually on a scale, such as 0 to 100. Finally, we calculate a weighted total score, which gives us a clear, transparent ranking of the technology's overall value. Let's look at an example. Imagine a breakthrough gene therapy for a rare childhood disease. Its cost per quality adjusted life year might be well above the usual willingness to pay threshold, meaning it could be rejected if cost effectiveness was the only measure. But MCDA lets decision makers give more weight to other factors, like the dramatic improvement in quality of life, the small size of the patient population, and the fact that there is no other available treatment. By doing this, MCDA gives decision makers a balanced and transparent way to justify coverage decisions that consider not just economics, but also fairness, innovation, and the real-world impact on patients and society. In this session, we explored the key tools that make health technology assessment such a powerful decision-making framework. We started with the four main economic evaluation models: budget impact analysis to understand financial impact, cost-benefit analysis to translate outcomes into monetary terms, cost-utility analysis to measure outcomes in quality-adjusted life years, and cost-minimization analysis to identify the most efficient option when outcomes are equivalent. We then looked at the Incremental Cost-Effectiveness Ratio, a cornerstone metric that tells us how much extra we spend to gain additional health benefit. We learned how quality-adjusted life years combine both the length and quality of life into a single measure, making comparisons across treatments possible. We also explored the willingness to pay threshold, which acts as a benchmark for determining whether an intervention offers good value for money. Finally, we went beyond cost effectiveness with multi-criteria decision analysis, a framework that incorporates multiple dimensions like equity, innovation, and patient need into the decision-making process, allowing for fairer and more transparent outcomes. These concepts together form the foundation for evidence-based, rational, and ethical healthcare resource allocation. As you reflect on this tutorial, think about how you can apply these principles in your own work, whether it's contributing to market access decisions, designing medical strategies, or communicating the value of new interventions. The more we use these tools effectively, the more we ensure that patients receive treatments that are not only innovative, but also equitable and sustainable for healthcare systems. Thank you for joining me in this session, and I encourage you to continue exploring health technology assessment as a way to elevate your impact on patient outcomes and healthcare decision-making.